Good morning, everyone. Welcome to the Mastering HCC Model version 28 Strategies for a Winning Path webinar. I'm Junaid Mahmood, your moderator for today's session. Before we start the session, let's take a moment to introduce our expert speakers. Joining us today are Zaima Ahmed, product owner at Persevia, and Dr. Shannon Decker. Dr. Shannon Decker is principal at VBC1 and has more than 20 years of experience in healthcare and most recently led teams in risk, quality, data and analytics, telehealth, COVID response, and delegation compliance. Of her more than 20 years of experience in healthcare, 15 include working with risk adjustment, quality, and Medicare. We're thrilled to have such a knowledgeable thought leader guide us through today's discussion. But before we begin, a few housekeeping items. If you have any technical issues during the webinar, please use the chat function to reach out to our support team. We encourage you to ask questions throughout the session using the Q&A feature, and we'll do our best to address them during the Q&A segment at the end. This webinar is being recorded and the recording will be made available to all registered participants afterwards. Now let's get started with our first speaker, Zaima Ahmed, who will walk us through the key differences between HCC Model V version 24 and the new version 28 update. Zaima, the virtual stage is all yours.
Thank you, Junaid. Can we go to the first slide, please? Thank you. Okay, so earlier this year, CMS released the advance notice and the calendar year 2024 announcement document containing the major changes to the Medicare Advantage risk adjustment model. And of the major changes was that CMS introduced a new and updated version 28 model. So now the new model includes changes to the capitation rate and the risk adjustment methodology. So let's begin by looking into the key changes from version 24 to version 28. Under the version 24 model, we have 86 HCCs with about 9,800 ICD-10 codes that map to an HCC for payment. While under the new and updated version 28 model, we have 115 payment HCCs. So that's an increase of 29 new HCCs. We also see a decline in the number of ICD-10 codes to around 7,700 codes that map to an HCC for payment. Additionally, there are 268 new ICD-10 codes that have been included this year. And some of the previous HCCs have been removed from the model. Next, please. Okay, so as already mentioned, there is an increase in the number of HCCs, and this is to capture more specific health conditions that accurately represent the health conditions of beneficiaries. So for example, we have the new HCC 35, which is the pancreas transplant status, HCC 227, which is the cardiomyopathy, and so on. Then there is the clinical reclassification of the HCCs, which means there has been a restructuring of the condition categories based on ICD-10 codes instead of the outdated ICD-9 coding system. There has been a decrease in the number of ICD-10 codes that map to the 115 HCCs. So that's around 2,200 diagnoses that no longer map to an HCC. And the reason for this is since ICD-10 has a much larger code set, it provides more specificity, especially for certain clinical categories like depression. And we'll touch more on the restructured HCCs later on in this presentation. Moreover, the version 28 model uses updated data years for model calibration. So it uses 2018 diagnosis and the 2019 fee-for-service expenditure data instead of 2014 diagnosis and 2015 fee-for-service expenditure data. Let's continue to the next slide, please. Okay. So here you'll notice there are several HCCs that have been removed. An example of this is HCC 21, which stands for protein calorie malnutrition under the version 24 model, but it corresponds to the category HCC 47 under the version 28, but it's been removed. Some other examples are HCC 88, angina pectoris. We also have HCC 265, which is atherosclerosis of arteries of the extremities, and many more. Then there are a number of new HCCs, such as HCC 51, Addison's and Cushing's disease, HCC 80, Crohn's disease. And again, we will further touch on how the new HCCs are significantly impacted by the model changes. Some of the existing HCCs have been renumbered. For example, the well-known diabetes group has been renumbered from HCC 17, 18, and 19 to HCC 36, 37, and 38. And you will notice that the coefficients or relative factors for HCCs have been updated under the new model. Yeah, next please. Okay, so before we dive into more details about the disease categories, I'd like to look at how the increase in diagnostic HCCs and the decrease in the ICD-10 codes reshape risk adjustment predictions. So firstly, over here, when there is a decrease in the number of ICD-10 codes mapping to HCCs, because the codes have either found to be redundant, duplicative, or no longer relevant, and so that this means the condition is either reclassified or merged, this can lead to the removal of that HCC category. So then this impacts financial predictions because certain ICD-10 codes indicate the presence of specific health conditions that may require more intensive or costly care. And essentially, this means that MA plans that are serving beneficiaries with greater healthcare needs would receive appropriately higher payments. And also, by eliminating lesser used ICD-10 codes, we can get precise HCCs that reflect possible changes to physician coding patterns for efficiency and accurate medical coding. And ultimately, this results in the adjustments in risk scores, which in turn affects the financial calculations and payments. Now, moving on to when the new version 28 model will be implemented. Next, please. Okay, so the technical adjustment will be phased in over the 3 years, starting calendar year 2024. Risk scores will be calculated as a blend of 67% using the version 24 model and 33% of the risk scores calculated with the updated version 28 model using the diagnosis with date of service from 2023. And as you can see here, in calendar year 2025, the blended percentages have flipped. And by 2026, 100% of the risk scores are to be calculated with the version 28 model only. Next, please. Okay, so version 28 within the VBC programs. So here you can see that the Medicare Advantage will impact clients starting calendar year 2024, and as explained, using the blended phase over the 3 years. For the MSSP program, the impact will differ depending on the start date with CMS, and for the ACO REACH program, the same impact as MA will apply here. So the risk scores calculated in calendar year 2024 will be based on 67% using the version 24, plus the 33% using the version 28 model. Now, if I could turn to the next slide, please, on disease categories that are significantly impacted by the model changes. Some of the impacted disease groups are diabetes, we have vascular disease, heart disease, major depressive disorder. Let's begin with diabetes. Diabetes has been renumbered and reclassified. There are now 4 diabetes HCCs that make up the diabetes group. HCC 35 is the new addition to the group, and it contains only one ICD-10 code, which is Z94.83. Previously, this code was part of the HCC 186 major organ transplant or replacement status under the version 24 model. Now, under the version 28 model, the ICD-10 codes that map to this HCC 186 have now all been classified into new HCCs, such as HCC 276, which is the lung transplant, HCC 62, which is the liver transplant, HCC 454, which is the stem cell, including bone marrow transplant, and so on. And what's interesting here is that the HCCs 36, 37, and 38 have all been constrained. And what this means is that these HCCs carry the same weight, relative factors, regardless of severity. So as in the previous version 24, if you had HCC 17 or 18, which is acute or chronic diabetes, they had a higher weight. Yeah, so next please. Okay, so the vascular disease group was also restructured. HCCs 107 and 108 were reconfigured into 3 new HCCs, HCCs 263, 264, and 267. In version 24, 475 ICD-10 codes mapped to HCC 107 and 108, and now 365 ICD-10 codes mapped to the version 28 vascular HCCs 263, 264, and 267. Peripheral vascular disease no longer holds value as it previously mapped to HCC 108. Okay, so the RAF weight has also changed, and these are more commonly known as risk adjustment factor. So here, for example, I have chronic hepatitis, which has increased by 0.038. Another example is HCC 198, multiple sclerosis, which differs by 0.224 between the versions, 0.423 in version 24, and now it's 0.647 in version 28. Next, please. Thank you. So for the heart disease group, there's a change in the way HCC 223 heart assist device and artificial heart can be coded. Beneficiaries must have a heart failure code from HCC 224, 225, or 226. Without this heart failure code, beneficiaries will not be assigned to HCC 223. And also the heart failure HCCs are constrained, having the same relative factors. Next, please. Okay. Here under the new model, there are now 5 psychiatric disease groups. Previously, there were 4 groups, and so we have HCC 151, 152, 153, 154, and 155. So over 50% of the ICDs that map to HCC 59, which is the major depressive, bipolar, and paranoid disorders in version 24, have been removed from the version 28 model. And the reason for this is because it did not predict the cost well, or most of the codes were related to diagnosis and remission. Okay, so and turning to the next slide, where I will demonstrate an in-depth example of HCCs and the corresponding RAS changing between the 2 models. Okay, thank you. Yeah, so here we have a male patient, age 67 years, non-dual, with diabetes and heart failure. You will notice that even if a diagnosis is an HCC in both versions, the actual RAF and HCC may be different. So for example here, diabetes with acute complications has a higher RAF in version 24 than version 28, and that's because all the diabetes under version 28 are constrained to 0.166. Here you'll notice heart failure and the demographics under version 28 are higher for this patient. However, the patient's total RAF is higher under the version 24 model, predominantly because of the diabetes RAF. However, in my next example, I'll present to you where the total RAF is higher under the version 28. Next, please. Thank you. Okay, so in this example, the patient has 6 HCCs, and the total RAF under version 28 is twice as high. We can see 5.332. And just wanted to point out that generally the RAF or HCCs under the version 28 are higher, and that's because of the recent data that's being used. So instead of using the 2014 and 15 data, is now using the 2018 and 2019 data. You will also see here the HCC 19 under version 24. So that's diabetes without complication, has a RAF of 0.105, whereas HCC 38 under version 28, which is the diabetes with glycemic, unspecified or no complications, has a RAF of 0.166, slightly higher than the HCC 19 under version 24. However, you will notice the biggest increase in the relative factors is for the disorders of immunity, which is HCC 114, and chronic ulcers, which is HCC 380 under version 28. So this means that organizations will want to identify the top HCCs amongst their patient population to examine and understand the potential impact of the 2 model versions. Moreover, you can see that there's a significant difference in the relative factors for the payment count conditions between the 2 models. So the payment count conditions have a higher relative weight under the version 28, but this weight is only assigned if the patient has 5 or more conditions. Previously, in version 24, it was at 4 or more conditions. And this also reminds me that the relative factors assigned to duly eligible patients are higher. So CMS will continue to make higher payments for an enrollee who's duly eligible compared to someone who's not, even though they may have the same health conditions. And CMS has also stated in the announcement document that there is a greater share of dual beneficiaries enrolling in MA. Now I will pass it on to Dr. Shannon Decker, who will share her expertise on the coding practices and financial strategies.
Thank you so much, Seema. I appreciate that overview. And it's a great segue into the next slide. And so talking about financial impact and strategies to succeed, and just want to remind everyone, that we've been seeing this evolution for some time. I can remember in the early days, it was all about that annual wellness exam that we would do, making sure to recapture conditions. And I think what we've seen, or what we're seeing, is this metamorphosis, right, to really capturing the whole of the care of the entire patient, trying to better patient outcomes. And so I want to encourage our audience to think about the long game versus just capturing points in time. And so really connecting all the pieces that are important to the long-term successful outcomes for our patients. Next slide. And so want to share with you that there is intended to be an impact. And so based on coverage year 2024, CMS is projecting that there will be a negative a decrease of 3.12%. That represents about 11 billion net savings to the Medicare Trust Fund in 2024. Now, I know a lot of folks, when they see that number, there's cause for concern. We don't want to go forward yet, so go ahead and go back. And just want to talk about this a little bit. Really, I think when we look at these numbers, number one, we're looking at correspondence, right? So looking at those conditions that used to risk adjust that no longer do, or as Seema took us through, looking at scores like with diabetes, right? What happens when now that they're constrained? What happens when you remove asymptomatic PAD from the model? But also, too, we need to consider there are new HCCs that are added, right? So all the things around, you know, as Zema had shared, the different psychological disorders that were now added. Also, too, I want folks to think about, you know, we know that there were organizations potentially that were maybe taking advantage of some of the model. And as we learned right in the final notice from CMS, that the focus really needs to be on reimbursing for care that's to take place in the following year, not 10 years from now, but in the following year. But there are opportunities, right, to make sure that your organization maintains its financial integrity, meaning that depending on where your patients are scored, that you're being reimbursed appropriately. And so just to share, you know, timeliness and accuracy will be important. Consider those new HCCs that have been added. Consider the importance of behavioral health. And then also, too, be considering social determinants of health. We're seeing lots about that. Definitely expect that to be rolled into the model, you know, making that prediction that that will have an impact. But all of these things will be important in managing the care of your patients. And want to give credit to Pareto for their study in analyzing the differences between V24 and V28. And so prior to applying coding intensity and normalization factors, the V28 model is resulting in a RAF decrease ranging from 7 to 22%. And again, you know, those 22% really believe apply to those organizations that potentially were slightly more aggressive with an average of about a 13% decrease. After applying the updated fee-for-service normalization factor, the RAF impact proposed by V28 is anywhere from a plus 2%. So as Zema showed us, right, there's opportunities to improve scores the more accurate and the more timely you are with your reporting, up to a negative 14%. And again, you know, concern over those conditions that are not necessarily substantiated in the medical record. But all in all, that comes out to be taking the extremes of the scale, right? Either positive or negative to about a 4% decrease. This is using the average of 11 coverage months. I know that some groups differ. Some apply 10, some apply the full 12, and about a $750 premium. And this RAF decreases, or excuse me, decrease translates to about an average of $418 per member per year decrease in the annual risk adjustment premiums. Next slide. And so just sharing some things that you might consider as you ready your organization to be prepared for the transition. Think about systems and workflows. So the transition from V28, which includes moving from ICD-9 to ICD-10 codes, requires preparing and sometimes upgrading systems like EHRs and patient population health systems to ensure they're up to the task. I want folks to think back, and if you're not familiar, you know, you may go and ask an old timer, but I believe it was about back in 2019, you know, diabetes updated its codes. And so we had to go back into the system and make those updates. And so using your coding team to go back to January 1 of 2023, because that's when V28 was applied, and making updates into the system to ensure that you're accurately capturing those codes. I'll share with you too, just being a leader and responsible for the operations of those systems and workflows. You know, there's all different places where information can potentially fall out or go awry. You know, encourage you to look at the EHRs that are providing you data. Are your provider specialty tables updated? You know, are you looking at both models? All of these things, right, will be important. Ensuring that you have complete encounter data, that you're submitting more than 4 diagnoses. As Zema showed, right, condition count could be an important factor in the work that you're doing. And again, because we want the score to really predict what expense is going to be, the closer you are, the more accurate and timely you are in calculating that score, the better off you're going to be, right? Because you're going to have payment then that corresponds with what we expect the cost of that patient to be. Education will be important as well. So communicating changes to all the individuals working in the organization and ensuring consistent workflow for every patient walking through the door, right? Educating staff members about new codes and processes will be crucial. I don't think you need to teach everyone about the new HCCs. Really, diagnosing is not going to change. Basic clinical care, right? How we care for patients is not going to change. Those things should stay the same. What will be important, though, is again, making sure that everyone understands that long-term game, right? And so ensuring to bring in all the various groups within your organization. If you're a provider office, making sure that your front office staff knows that those patients need to get in and need to be seen. If you're the MA that's setting up the room, right, that you're flagging the chart to make sure that the physician addresses all the appropriate conditions that need to be addressed. If you're the physician, making sure that your medical record is completely signed and dated with your credentials, right, making sure that your EMR is set up. If you're an MSO, a provider risk-bearing organization, or a health plan, you're going to want to make sure that finance understands the importance, right? That quality is connected as well, that your medical directorate is able to speak to the other doctors within your network. And so all these opportunities, right? Your customer service line knows that when a patient calls in or members are enrolled, that they're getting in their packets reminders to get their annual wellness exam or to make sure to see their physician on a regular basis. And so all of these things will be important. The other thing that I think that we should notice, because there's that emphasis, and I'm going to keep saying it, that long-term game, and so looking at continuity of care, I know that within our industry, we've used a lot of acronyms, right? We've used MEET, we've used DSP. I'm going to introduce a new one if you haven't heard it already, but think about SLAP, right? So making sure to status that patient, link any conditions, provide an adequate and appropriate assessment, as well as a plan that corresponds to that assessment. And the reason why I say that is we know, right, that if you have diabetes, it should be evident in the medical record, and we should see continuity of care. One of the things that we don't want to see, right, is the misuse of codes or codes appearing for the purpose of adding to that RAF score. It really should be, again, conditions that are being treated, that are being cared for the patient. And so if physicians are, our clinicians are documenting the conditions in which they're managing and treating, even looking at what Zyma had presented, those are real models of patients and definitely possible if you're providing, again, those complete and accurate encounters. Managing two different models, what I would recommend is that you're calculating for yourself the RAF score both on V24 as well as V28 and providing crosswalks. Really have a good understanding. Make sure to, I would recommend always taking a snapshot of your system so that you have data to go back to. A lot of times what we do is we make upgrades and then there's no way to go back and double check things. And so to the extent that you can manage a separate, what I used to call a clinical performance database, to be able to look at those snapshots of your data and compare over time. I'm also a big believer in triangulation. And so if you're calculating your score internally, consider other groups out there that can potentially calculate scores for you so that you can compare and make sure that, there's no gaps in the work that anyone is doing. And I can tell you, I have seen gaps internally from my own teams when we've built tools to even our vendor partners where things have been dropped out. And so definitely something that you want to attend to. And again, making sure to calculate both V24 and V28 and then providing that crosswalk. And then the other piece here that will be a challenge will be forecasting patient severity. And so it'll be important to predict severity of patients. Here's the thing you got to understand, right, is that now we've moved from V24, which looked at different conditions, to V28, which is looking at another set. Does that mean that you forget about what was captured in V24? Absolutely not. And I'm going to speak specifically here for a second about peripheral vascular disease. Do you stop testing because 108 is no longer an HCC? Absolutely not, right? What you want to make sure that you're doing is capturing the full progression, right, of that patient's health. And so if you're testing for asymptomatic PAD, think about all the things that you can do with that information, right? You can provide behavioral counseling, improve the outcomes of that patient. Again, remember, I said it's a long-term game. It's not a point in time. And then also too, we know, right, statistically that there is a typical trajectory with every disease progression. And so you're going to be watching for that. You're going to want to make sure that you document it. What you don't want to do in this model, especially because of the way, right, things have shifted, is you don't want to get behind the proverbial 8 ball. You want to make sure that you're capturing that patient's condition as timely and as accurately as possible. And so real-time data, real-time diagnoses, and the reporting of those diagnoses is going to be important. Not waiting 90 days, right, to file a claim, not waiting to your retrospective review. The sooner that you can submit these diagnoses to either your clearinghouse, your health plan partner, CMS, whoever the person is that you're submitting that data to, the better, so that it gets picked up in the earliest sweeps period. That's the way that you're going to be able to control for any volatility in any of the revenue and the financial, the reimbursements that you might be receiving. And so again, super important to line up with the reimbursement schedule and the sweep schedule, which is different, right, than a lot of times what we're thinking about when we're seeing patients. Next slide. And so just to recap, and how you need to prepare, again, understand the HCC coding guidelines and principles. Think about it as a long-term gain, making sure that patients are being seen regularly. Not really a lot of difference to our physician partners. We want them to capture, right? What are they treating the patient for? And it doesn't always have to be active treatment, right? It could be instances of watchful waiting, but if you note a condition that's significant to that patient, and it should be document it fully, and again, include that status linking assessment and plan. Analyze what V28 means for your population. Going back to that thinking about, what are the things that we expect for that patient? If you're testing for asymptomatic PAD, being able to document that in the record so that you're watching, right? So that you're trying to control and manage the patient. Think about, too, the other mechanisms that go into value-based care and why it's so important. And so that long game, total cost of care, you're wanting to make sure that we're managing these conditions. It's much better, if I look at the price difference between a patient who has diabetes, we know, I'm just going to apply some statistics here, we know within the first 3 years, most diabetic patients have some manifestation, right? Some symptom, some complication. And so usually it has to do with the eyes is where the complication is first seen. In fact, oftentimes that's how a diagnosis is arrived at. But that patient, right, when they're uncomplicated, the reimbursement, the care is much less than, say, if the patient has some complication and a manifestation. And I'll just use, since I brought up eye disease, blindness associated with diabetic retinopathy, the cost goes up 5-6 times in a matter of a few years. And so if you're able to capture that condition early, manage it, monitor it, capture it, right, as soon as there's any change in that condition, that will be important, because then you'll be managing your long-term total cost of care. And so not overspending, right, in programs or becoming surprised when you have an inpatient admission that you didn't account for because you didn't get your data in soon enough, right? You didn't get that diagnosis documented in the medical record and submitted. That's really what this model is intended to do, right? It's intended to have the monies available to you at a time, closer in time, because that's what V28 is intended to do, so that you can support the care of that patient. And then also too, think about your quality programs. Wouldn't it be great if every diabetic got their diabetic retinopathy exam every year, and through behavioral counseling and intervention that you were able to ensure that they didn't have some of those more extreme complications? Not only would it improve patient experience, right? But also to improve quality. And for those that don't know, when you look at these value-based care contracts, oftentimes quality and even total cost of care are first in those contracts before there's any mention of risk adjustment. And so if you're not doing well on your quality work, you really need to take a look at that, because there won't be any benefit from risk adjustment. It really is that whole package that you need to attend to. The other component, improve CDI. When I think of CDI, I don't think of it as clinical documentation improvement. I see it as clinical documentation integrity. And so that's really, again, about making sure that our clinicians are documenting the conditions that are appropriate for that patient. It's not the alpha and the omega, right? Right down the litany of everything that could possibly be wrong with the patient any longer. It's about really addressing those conditions that are true for the patient that you are addressing in the office. And then leverage technology. Think about suspecting, think about your data feeds. Suspecting will change, right? It'll still be important to capture the things that we were capturing in V24 so that you can be ready for V28. So when that asymptomatic peripheral vascular disease patient, right, becomes symptomatic, you're ready and you can make sure that you have the information available to address that. Next slide. And so what I think you need to think about, especially to prepare your organization, is think about building your data pipeline. There's so much data available to us. Interoperability, I think, for many is still a dream and not a reality. It needs to become a reality. And so getting the data that's available to you, there's a wealth of lab data, pharmacy data, encounter data, right? I had mentioned before about making sure that you have the appropriate physician specialty codes, that you're adhering, to the risk score runs, that you're submitting your capitated encounters. Make sure, and this goes to the point about making sure organizations, right, are all aligned. I have seen it many times at provider groups, at health plans, where a provider group might submit an annual wellness exam. Their clearinghouse holds back the encounter because it's capitated, because the claims team didn't know. That capitated encounter includes very important diagnostic data, right, that goes into the calculation of those risk scores. You need to make sure that it goes out the door. I've seen where health plans get those capitated claims, and because the way the system was set up, the clearinghouse on their end rejected it, right? And so they never got the data and they couldn't figure out why. And so again, because timeliness, not that retrospective won't be an important strategy, it will be, being prospective, right, and concurrent is going to be even more important. And so making sure that everybody is talking, that you're checking the systems, that the claims and the encounters that are being submitted match up with, your claims feeds, match up with, if you're a Medicare Advantage organization, you're getting MAO4 files. If you're an ACO REACH organization, you're getting CCLF files, and you're making sure that there is correspondence, right, between the medical record, what you submitted, and what's actually getting accounted. I mapped an organization once with my team, and we discovered there were 9 different points in which data falls out just from the time a clinician submits a claim to a provider group to the point that it goes off to the health plan. That's not to mention, right, what happens when it gets to the health plan. And so really important to take a look at your data pipeline, bringing in all those pieces of data, and then ensuring, right, that everything that you send on its way gets to the other side. Number 2, code to the highest level of specificity. Always, right? The mainstay here in the work that we do. But again, even more important to do it in a more timely fashion. And so again, thinking about that status linking assessment and plan, having timely and correct data. You want to check in too with your senior patients more than once a year. We know, by way of statistics, that most seniors should be seen 5 to 8 times a year on average. That's what I see too when I look at encounter data. Actually, it's as much as 9 visits a year. Some of your sicker patients may have more, but on average, if you're not seeing your patients, I would say I'll widen it a little bit, 4 to 9 times a year. Those patients that are 60, 65 and older, you should be. And if you're not seeing that, or you know you're seeing them, but you're not seeing evidence in the encounter data, look at why, right? It could be some of those aforementioned reasons that I had shared. And then number 3, look at whole person care. So look at all the elements, that 3-legged stool that I had mentioned earlier for value-based care. You have to look at risk, but you also have to look at your quality performance, and you have to be thinking about social determinants of health. And so really think about the long-term gain, patient outcomes rather than an HCC score, right? Somewhere, I really think that we got misaligned from our mission as being these good stewards of healthcare. If we focus on the right end, right, the benefits will follow. And forgive me if I've messed up the attribution, but I think about Buddha, right? The right intention, improving patient outcomes, will lead to right action, right? Providing that continuity of care, that long-term gain for the patient, which will then result in better outcomes, better managed care, right? Controlling of cost, ensuring that patients are getting that quintuple aim, the right care at the right time in the right setting, right? Reducing patient burnout and ensuring that we have health equity, all super important. I want to thank Persivia for hosting this webinar today, and just share that, as a leader who has looked at a lot of different platforms out there, evaluated, over 16 in my last RFP, looking at different platforms. Some of the things that were important to me was finding things that could provide point of care information to the physician when it mattered, right? When the patient was in front of them in the office, was able to bring in multiple data sources like we talk about here on point number 1, being able to take that information regardless of the model, right? Bring in all that information, standardize it, make it so that that narrative that you're getting about the patient is cogent, makes sense, and is actionable. And so out of all the different platforms that I've evaluated, really think that Persivia is a standout and is best in class. And so I'm going to turn it back over to Zema at this point to talk a little bit more about Persivia and how it supports some of the important things that I've mentioned that you should be looking at in order to prepare your organization to be successful in capturing the health of your patients. Zema?
Thank you, Dr. Shannon. Janae, can we go to the next slide, please? Okay, so let's consider how partnering with Persivia can lead you to success. So our platform is built on a unified data model, and our main platform, which is CareSpace, leverages the power of data from prescriptive, descriptive, and predictive, as well as generative AI to drive the real value from the data. CareSpace is also builds a dynamic longitudinal patient record by ingesting, curating, and normalizing data from hundreds of patient sources, such as claims, clinical, HIE, ADTs, SDOH, devices, and more. And at the heart of CareSpace is our AI engine called Soliton, which does all the magic with the data that's collected and drives highly relevant and clinical actionable insights. It helps automated workflows and processes, and it also has a built-in CDI workflow that ensures complete and accurate documentation. And at Persevia, we also support all VVC initiatives that any organization might have. Next slide, please. Diving a little more into the beauty of our platform, and that is each and every module is built within the system. So that means there is no third party involved, and that gives us the full power and control over the system, and also gives us the edge to help meet the varying needs of the different organizations. And our platform also delivers a well-organized infrastructure that uses microservices-based architecture, and any module or capability can be activated for any client at any point in time based on their needs. And finally, I want to conclude by illustrating one of our success stories. Next slide, please. Okay, so here we had an Ohio-based MG with a patient population of approximately 116,000 individuals. We performed comprehensive data extraction from multiple EHRs, and by extracting longitudinal patient record, by aggregating both the clinical and claims data. And then we applied NLP and machine learning to identify these hidden codes in the physician notes and HCC opportunities in the patient's chart, and then recommended the HCCs at the point of care. As a result, we were able to see a 120% increase in the HCC capture rate using our machine learning and NLP. This gave us an estimated average lift of 0.81, and we saw about 2.54 average increase in the HCC opportunities. More of this case study can be found on our Persevia website. That's all from me. Thank you all for listening, and now we can proceed to the Q&A.
Thanks, Zaima and Dr. Decker, for a wonderful session. So it's now time to transition to the Q&A session, where we get to address all your questions and engage further with our panel of experts. So our first question here is directed to Dr. Decker, and it says, it seems that the changes could be harmful to already underserved Medicare beneficiaries, like, for example, diabetes. The affected beneficiaries with diabetes are more likely than the average Medicare beneficiaries to be age 75 or older, Black or Hispanic, and duly eligible for Medicaid. They are also more likely to have low income, have lower levels of education, and experience food insecurity. What's the strategy to deal with this?
Great question, and thank you so much. You didn't start with an easy one, did you? I would absolutely agree with you. And so I think that, to Zaima's point earlier, right, the coefficients have changed for those patients that are duly eligible, have multiple conditions. Make sure that you're recording, right, and that you're getting all of that information. And then I think that there's opportunities, and we're already seeing this. There's some organizations that are doing this very well. And if you're not sure, reach out to me. But there's an opportunity, right, to look at differentiated care teams. And so, do you have social workers on your care teams? Do you have pharmacists on your care teams? What type of technology are you using to reach out to these patients? How are you involving, I think, community-based organizations, especially in populations, right, where you're looking for opportunities to integrate. You're the big four in health plan. There might be some reservation as to why you want to look at a particular patient. And so how are you leveraging the community-based organizations that are already in these communities and neighborhoods and helping some of these individuals? I think that there's an opportunity for us to become more connected. And again, going back to that interoperability, the data that we have out there is massive, right? How can we sort it out, make it so that it makes sense, and then be able to use that to form tighter partnerships, right, with the communities and the groups that we serve, so that we can keep that closeness with the patients and the members that are ours.
Thank you, Dr. Decker. I would request all the attendees to drop their questions in the question panel. Moving on to the second question, seems like there's another question for you, Dr. Decker. The question is, are the SDOH codes part of the version 28, or is it something on the cards?
Not yet, but definitely something in the cards. Have been part of some discussions, nothing formal, but part of some discussions where there is recognition, right, that social determinants of health are important in how they intersect with how one takes up healthcare. And you know, if you haven't done these types of simulations with your organizations, recommend that you do. But thinking about if you don't have money for, say, you know, transportation to get to the doctor, or you know, the ability to get your full prescriptions and those types of things, how that, you know, impacts thinking, how poverty, and I'm just using one component, right, of SDOH, there's lots of others, but how that really impacts your thinking and shapes how you know, your action. And so there's definitely recognition in the community and in, you know, the powers that be, that SDOH is very important. And I think we definitely saw that play out and well illustrated during the pandemic, right? A lot of us moved to telehealth. We found that it wasn't always necessarily devices that people lacked, but broadband access, especially in our rural areas. And so all of these things, right, are important. I can tell you, I've heard mumblings that there is the thought that there is not to add any additional monies to the programs, but that we'll have to find ways to recirculate. And so I think V28 is one of the first steps, right, in that direction of how to reclass or recirculate monies to support SDOH and programs, right, that will help with social determinants of health. And I think we're already even starting to see that with some of the changes in the coefficients around dual eligibility and some of the other things too.
Thank you, Dr. Decker. So we have another question, and it is pointed to Zaima. And the question goes, where can I find the full list of HCC differences between the current and the new updated CMS HCC risk adjustment models by disease group?
Thank you, Junaid. Okay, yes, the full list of the differences by disease groups can be found in the advanced notice, starting, I think, on page 50. Yeah.
Thank you, Zaima. We've come to the end of what has been an incredibly insightful and engaging webinar. We hope you found this experience as enlightening as we have. As a reminder, this webinar has been recorded and you'll receive a link to access it shortly. Thank you once again for joining us today. Have a wonderful rest of the day. Take care.